Hello, here at Machaon Diagnostics, we've developed a 2-day next-generation sequencing test for the hyperinflammatory disorder known as Hemophagocytic lymphohistiocytosis, or HLH. Specifically, I'd like to talk about the effect of this test availability on better patient outcomes and ability of getting patients into new clinical trials. My name is Violet Votin. I'm a clinical research scientist in the genetics group at Machaon Diagnostics. Feel free to contact me with any questions about the HLH panel. As you know, HLH is a life-threatening, fast-progressing disease. Sometimes untreated patients can go from presentation to death within a week. Knowing the genetic cause of HLH is a big part of the diagnosis, and being able to do that in 2 days is game-changing. HLH, the typical familial or primary HLH, often seen in children, usually involves a variant or two in a core group of 10 genes. So patients are either homozygous or compound heterozygous for variants. Some of these genes are involved in albinism, you'll notice. 2 of the genes, XIAP and NLRC4, are interested in are part of IL-18 mediated macrophage activation syndromes. Children with these variants are currently eligible for a trial of IL-18 binding protein sponsored by AB2 Bio. Adult onset HLH, sometimes called secondary HLH or sporadic HLH, tends to have a trigger such as infection or malignancy, but also has a genetic component, often a variant in these same genes. We wanted to understand what was the clinical utility of offering this panel. Our first panel was a targeted sequencing panel for the next generation sequencing platform and involved 10 genes, as listed on the previous slide. As of October 2019, when I was preparing this talk for the Histiocyte Society meeting in Memphis, 32 patient samples had been run. 7 of those were positive. I wanted to ask the clinicians who had received these positive reports and received them within 2 business days, how did that diagnosis so quickly change their treatment options and change the patient outcomes, most importantly? I'd like to talk about 3 particular cases. In the first case study, there's a 6-week-old female who was diagnosed initially with albinism, congenital diaphragmatic hernia, multiple organ failure, a very sick baby. The problem was that they weren't able to start treating for HLH because of the risks, and not knowing that the baby definitely had HLH, the benefits were unclear. So we did testing, targeted NGS panels I mentioned with 10 genes. The result, a heterozygous variant in RAD27A. This has been shown in a very recent paper to be involved in HLH associated with a HLH patient, as well as a likely benign variant in the LIS gene. So the new diagnosis is clearly Grosselli syndrome 2, HLH, definitively. This means that the patient was eligible to be offered Gamifant, a fairly recently approved drug for HLH. The comment of the clinicians, 2-day turnaround was very helpful in interpreting the lab abnormalities and critical illness of it, in making an appropriate treatment plan and providing more accurate prognosis. The next case was a 6-month-old female. Initially, IL-18 was tested, and based on that, a diagnosis of macrophage activation syndrome was suggested, definitely based on symptoms not systemic juvenile idiopathic arthritis. The problem is that some of the blood tests required to really confirm this diagnosis took a lot longer than our genetic panel, longer than 2 days. Some of them were affected by drugs the patient needed to take, and some required more blood or cells than was available in this very young infant. So the testing we did is this targeted NGS panel. The result, a heterozygous variant in PRF1. This has been reported in a patient with HLH who is homozygous. Interestingly, outside of the trial for which part of which this patient was sequenced, they had done whole exome sequencing and gotten the same result, of course, many weeks later. It's interesting that this PRF1 variant that was heterozygous was consistent with the flow cytometry results that showed that perforin was only slightly less than normal. Okay, so the new diagnosis is HLH, and that means the treatment that opened up was HLH94 and was successful for this patient. Next step, it would be interesting to know what the second variant might have been. The current HLH panel might detect that because we do now cover deep intronic variants that are known to be pathogenic and large inversion in ONC13D that is known to be pathogenic. Finally, the third case study is a 1-month-old male. In this case, the diagnosis initially was lysine protein intolerance and possibly many other options in the differential diagnosis. They began with what they could as far as what they thought the problem was, so diet modification for LPI. They hadn't started any other trial therapy or etoposide. The problem The presentation was not classical sepsis like HLH, so that didn't help them definitively say that it met all the criteria for HLH by 2004. No IL-18 results were yet available. The testing we did again was targeted NGS panel. This is particularly quick. The specimen was collected on a Wednesday, and the final report was sent on Friday. The result, a heterozygous variant in NLRC4, as well as a variant of unknown significance. The new diagnosis then was quite clear: an autosomal dominant NLRC4 macrophage activation syndrome. And that means the patient was eligible for a tatakinig alpha trial, an AB2 bio trial using recombinant human IL-18 binding protein. Because the results came back so quickly in 2 days, the patient could be quickly enrolled and was successfully treated as part of that trial. The physician and the expert in HLH mentioned pretty powerful this test was. Rapid genetic testing is critical. This means patients see directed therapies quicker and experience less distress waiting for results and directed therapy. At the time, that variant that we saw in that patient was novel. It had not been seen or published before. And it's interesting, as we have more and more patients, we've currently sequenced about 90 patients as of April 2020. We come across some variants that had been considered novel. For example, this one was found in 2 unrelated subjects out of the 33 we had sequenced at that time, and was since published since we first saw it. The takeaway then from these 3 babies who were successfully diagnosed with HLH is that faster genetic results are clinically useful. You'll notice here that the lab 1, which is the most typically used lab in the US for HLH genetic testing, has a turnaround time of about 6 weeks, quite far out from the bullseye of knowing it right away, of course. Lab 2 and Lab 3 had similar couple-week turnaround times according to their websites, whereas Machaon Diagnostics can offer a turnaround time for stat samples of only 2 days. So the current HLH panel offered by Machaon Diagnostics is not just fast, it's actually more clinically sensitive. Here I'm showing the number of genes covered by our panel, 36, as well as the number of genes covered by some other labs, including one of the most commonly used ones. And they have about half as many genes, so they aren't able to rule out as many other differential diagnoses and include as much sensitivity for underlying disorders that are associated with HLH. Furthermore, it turns out that previously patients have seemingly one heterozygous UNC13D variant, but it turns out a lot of those patients will have either a deep intronic variant or a pathogenic known large inversion in UNC13D. Most of them would. Our panel tests for both of these, the 253 kb inversion, which is particularly common in Northern Europe, and several deep intronic variants, including these 2, which are common in Korea, seem to have a founder effect. Not every lab, again, offers those 2 in addition, because they're not necessarily detectable from straight NGS and definitely not by whole exome sequencing. So we are comprehensive, which means more clinical sensitivity. And of course, on top of that, the number of genes seems to be an inverse relationship to the turnaround. We still do have a 2-day turnaround time compared to, again, 6 weeks in some cases for a very popular lab. The genes in the current panel are based on literature. As we were putting together this panel in 2019, we are happy to add or subtract genes as needed for different projects or as more literature becomes available. To summarize, here is the HLH genetic panel now offered at Machaon Diagnostic. Our turnaround time for routine samples is 1 week. Our turnaround time for stat samples is 2 consecutive business days. We have 36 genes sequenced with greater than 97% coverage, sequencing with a read depth of 200 to 2,000 fold, about 10 to 100 times more than whole exome. We also use PCR to detect the large UNC13D inversion. The clinical sensitivity is at least 90%. The clinical justification is, as we've seen in the 3 case studies, rapid diagnosis of HLH by genetics means appropriate therapy can be initiated sooner for the patient. Lives are saved, resources are saved, outcomes are improved. Our competitive advantage is that we have the most comprehensive HLH genetic panel offered with the shortest turnaround time, as far as we know. And this can be summed up by a satisfied client, a physician treating HLH patients who said this is the best genetics product and almost instantaneous. The workflow is patent pending since we've launched this test in 2019. Thank you so much for listening. Thank you also if you would like to help us by sending a UNC13D inversion sample That is a sample that you think might have an UNC13D inversion because it already has one other heterozygous UNC13D. Thanks to the doctors who shared their cases with us kindly, as well as AB2 Bio, for whom we are doing the genetic part of the patient recruitment for trial for cytokinic alpha. Thank you also to the great team at Machaon Diagnostics. Please feel free to reach out to us to ask about any other genetic panels or HLH and associated tests, as well as coagulation and platelet diagnostics.